Welcome to YouTube channel of Endocrine Society of India. This osteoporosis webinar jointly organized by Pediatric Endocrinology and Skeletal Taskforces covers pediatric bone diseases, fracture risk, research collaborations, patient guidance, and treatment options.
As a webinar on occasion which is going to conclude the osteoporosis thematic webinar, we are representing the Pediatric Endocrinology Task Force. Along with me, Dr. Lakshmi Nagendra, she is coordinating the activities of the Skeletal Health Task Force. So this webinar is designed for helping the practitioners to learn about endocrinology and the aspects of bone aspects across the lifespan, that is from the pediatric to the adult side. So over to Dr. Lakshmi Nagendra, please introduce the team as well.
I think Dr. Mohan has given a good introduction to the task forces and today's activities. I think we're already running late. Over to Dr. Andresia to begin the proceedings.
She's actually out of this list. I think she's not in that webinar now, right now. That's why I just told maybe you can take
Okay. Okay. So, good evening, everyone. We are good to start, and I would invite our President, Endocrine Society of India, Dr. Kaushik Pandit, to begin with opening remarks.
Good evening, and welcome all the members of the Endocrine Society of India, as well as people who are interested into this webinar. This is an effort by the Endocrine Society of India, especially the Task Force on Osteoporosis, who are coordinating this webinar. This is just to let people know that Endocrine Society of India is also very importantly associated, interested, and have got some proposal to go ahead with the bone health, especially in the field of osteoporosis. And to kickstart that one, this is a webinar that we have started in 2025 to further our interest in the field of osteoporosis. I once again welcome everybody who have joined and who are interested and will be interested in the bone health, especially the endocrine aspect of the bone health. With these few words, let me go back to Lakshmi for conducting the session.
Thank you, sir. I would request our Secretary, Endocrine Society of India, KVS Harikumar, sir, to give his opening remarks.
Good evening, everybody. And thanks to both the ESI Skeletal Task Force and Pediatric Task Force, Dr. Mohan and Dr. Lakshmi and the entire team for putting up a good show. The issue remains that the baby steps are important to actually have a good bone health. So it is rightfully placed that both the skeletal as well as the pediatric task forces are combined, so that it is not that the osteoporosis is a problem of only elderly. The idea is not to have a problem in the elderly, so that you take steps from the beginning. That is what the idea behind combining these two, and thanks to both these members and all other faculty and the panelists and the other members who are listening. So we're going to have excellent sessions in the next couple of hours to highlight some of the bone issues in the pediatrics as well as in the adults. And any of these questions will be answered by all the experts who have joined here. I wish all the best to all the organizers and have a great learning exercise. Thank you.
Thank you, sir. Indeed, very well said. I think the first 1,000 days of life of a baby is very important for, many things we talk about: thyroid, congenital hypothyroidism, nutrition. I think we should also stress about bone health right from the beginning, the optimal calcium intake, optimal nutrition, optimal exercises, which can start from childhood, go on into adolescence, so that, the peak bone mass is achieved and we prevent osteoporosis. And I think this is a first good step that Endocrine Society of India has taken to bring about this awareness. So now we are honored to have with us Dr. Thomas Paul, who has amazing work in the field of osteoporosis. Sorry, I would request others to mute. So we have with us Dr. Thomas Paul, who has numerous original publications in the field of osteoporosis, to many of us in the field. Over to you, sir, for your opening remarks.
Thanks, Lakshmi. And Thanks, Harry, and I welcome all of you to this important and interesting webinar pertaining to osteoporosis. Of course, as Lakshmi said, it's a joint collaboration of ESI Pediatric and Adult Skeletal Task Force. We know that osteoporosis and bone fragility seen across from pediatrics to geriatrics. So it's very important to have a healthy bones from the childhood. If you look at the problem after menopause in India, about 40% of the Indian women have osteoporosis, about 25 to 30% have prevalent vertebral fractures, 20% of the women after 60 years after hip fracture die within 1 year. Sad state is less than 5% of this population are evaluated and treated. Today, we have the opportunity to listen to the experts in this area who will enhance our knowledge, and we all will be benefited. Over to you, Lakshmi. All the best.
Thank you. Thank you, sir. Thank you, sir. Thank you for those wonderful remarks. We can now go ahead with the scientific sessions, and we have a very young, dynamic endocrinologist to conduct the sessions with us. Over to Dr. Andres Yajros.
Dr. Andresa?
Yes, sir. Thank you, Lakshmi ma'am and Mohan Shanai sir. So I would like to invite our first speaker for the day. Sir, I'm having a very unstable connection because it's raining cats and dogs here. That's why my net is getting disconnected at times. So I would like to Dr. V. Nagesh sir onto the stage. Sir is a prolific academic inspiration to all of the young endocrinologists, and on behalf of ESI and Pediatric Endocrinology and Skeletal Task Force, I'd like to invite sir to conduct the seminar based on spectrum of pediatric bone disorders. And sir has got a stellar CV also. Sir, please, I do invite you to conduct the session on behalf of everyone.
Thank you, Andresa. Over to Dr. Nagesh, sir. Can you just stop sharing the screen, technical team? Yeah.
So two cases. The first one is a case of recurrent pneumonia and gross motor delay. To give you a brief overview, a 2-year, 7-month-old who presented with shortness of breath for the past 2 days, had recurrent lower respiratory tract infection since 11 months of age. He had 2 prior admissions for bronchopneumonia, and he's been in and out of the hospital almost most of the time. Since the time he'd been referred to me till the time he'd been referred to me, he'd been in the hospital for almost a period of 2 years. He had history of failure to thrive, which was initially noticed at the age of 6 months. Did not give any history of constipation or poor feeding, any history of polyuria or polydipsia, or no history of cyanosis. Recurrent vomitings or gastroenteritis or frothy stools, which were actually taken for malabsorption. Did not have any chronic renal or liver disease, no history of seizures. Did not have any history of use of anti-epileptic drugs or anti-tubercular drugs. If we go to the birth history, he was born of 3rd-degree consanguinity. The birth history was normal with a birth weight of 2.8 kilos. He'd been immunized as per schedule. As far as his development was concerned, he had a gross motor delay. Rest of the development, fine motor, personal, social, and speech were perfectly normal and age appropriate. At 2 years and 7 months of age, he had a height of 74 centimeters, which was less than 3rd centile for age, corresponding to a height age of 1 year. Weight was 8.5 kilos, which was less than 3rd centile, corresponding to a weight age of 1 year. He had a rachitic rosary, Harrison sulcus, wrist widening, generalized hypotonia, and a wide anterior fontanelle, which would have fused by the time of 18 months. The heart rate was pretty high at 169, and he also had high respiratory rate. Blood pressure was slightly high for the age. Oxygen saturation was 60% on room air, and that was why he was on the ventilator. Bilateral V's in the lungs. Heart was normal, per abdomen, slight hepatomegaly, probably because of the respiratory distress, and he was conscious. Initially, at admission, he was started on IV fluids and antibiotics because they suspected bronchopneumonia. Then once the saturation started going down, he was put on oxygen inhalation. And subsequently, in view of poor respiratory distress and perfusion, he had elective intubation and mechanical ventilation. So this was the condition at which he had been referred to me, and when I had a look at his investigations, the corrected calcium was low at 6.2. Phosphorus was also low. Very high alkaline phosphatase. 25 hydroxy vitamin D was more than 70 nanograms per ml, probably because he'd been given multiple doses of vitamin D injections. PTH was elevated, pointing towards a secondary hyperparathyroidism. Low normal magnesium for a child. Creatinine was normal, LFT was normal, and ABG showed a respiratory acidosis with a compensatory metabolic alkalosis. If you can look at the X-rays, you can classically see osteopenia, slight cupping and fraying of the epiphysis. And the bones are slightly malformed because of probably because of increased osteoid. And you can see severe osteopenia. With this picture and the current investigation picture we had, the initial differentials were resistant rickets, looking at either VDDR1 or VDDR2 because he had not actually responded to vitamin D injections and calcium supplementation. Another possibility we had with this picture was distal RTA, and the fourth was hypophosphatemic rickets, looking at the spectrum of rickets. If we had a review of the old records, he'd been evaluated by a nephrologist and a pediatrician. They initially suspected renal rickets. On 13/8/2011, because this is a very old and interesting case, that was why I dug it up for this presentation. The phosphorus was 2 calcium was 8.4. Phosphorus was 2.4 and alkaline phosphatase was 1100. It was the first time he had been given Arachidol 4.8 lakh units cumulative, which is an extremely high dose for such a young child. Subsequently, he'd been in and out of the hospital, and the reports I had seen later on were corrected calcium was 6.6. It had not gone up. Phosphorus was almost at the same point. Alkaline phosphatase was 962. 25 hydroxy vitamin D was more than 70 nanograms per ml, and 125 OHD3 was 33.7, which was low. And the acid load test was negative, which ruled out a distal RTA. So, because given the fact that he had low calcium, low phosphorus, increased alkaline phosphatase, and low 125 hydroxy vitamin D in the setting of an elevated 25 hydroxy vitamin D, the nephrologist provisionally diagnosed a vitamin D dependent rickets type 1, and he was started on calcium 375 milligrams per day and activated vitamin D 0.25 mg. Subsequently, he did not show much response. 2 months down the line, the calcium had improved slightly to 7.7. Phosphorus was still on the lower side, and alk phos had gone up, which is what is expected when somebody is initially started on vitamin D. 2 more months down the line, the calcium had dropped down further. Phosphorus had slightly improved, and alk phos was still very high. This supplementation and rechecking continued for almost 1.5 years. In May 2013, he still had a low calcium. Phosphorus was 2.3 milligrams per deciliter, and alkaline phosphatase was 1644, which were the levels at the time of the subsequent, the child had remained admitted all through this while. Over a period of time, he'd started once in a while when he had slightly improved, he was allowed to go home, but he usually came back within a week or 10 days. Because of the deterioration, he'd been started on ventilation, and it was at this point that he was referred to me just a few months when I started my initial practice as an endocrinologist. By then, the nephrologist had made a provisional diagnosis of VDDR1. Since this was not responding to treatment, he labeled it as a possible VDDR2 and referred it to the endocrinologist. So when I had a look at this child, it was very obvious that this was not hypophosphatemic rickets because the calcium was low. This was not a case of renal tubular acidosis. We were probably dealing, and it was unlikely to be VDDR1 because the response was very poor to calcitriol. So we went ahead with a provisional diagnosis of vitamin D dependent rickets type 2. Started him on IV calcium 60 mg per kg per day and activated vitamin D 0.25 mg twice daily, gradually up titrated to 4 times a day. Continued on ventilation, IV fluids, and maintenance antibiotics. Over a period of time, the general condition improved. And 14 weeks down the line, it took a huge amount of time before this patient could be stabilized. The general condition improved and he was taken off ventilator after 14 weeks. He had even developed severe constipation during the course of this therapy, but we did not go slow on the calcium. We just gave him a laxative and continued with calcium and activated vitamin D because that was the only thing which was showing response, and he was continued on BiPAP. General condition steadily improved, and after a cumulative hospitalization of 21.5 months, he was discharged on 800 mg of calcium, 100 mg of vitamin D, and 1 mg of 4 times 0.25 of 125 hydroxy vitamin D, and I had also started him on a small dose of hydrochlorothiazide to prevent hypercalciuria. The general condition steadily improved. He was eventually taken off BiPAP after the end of 3 months of discharge. And for the first time in his life, he started gaining weight and went on to 4.5 centimeters in 6 months. If you actually look at the growth chart, you can see the rapid increase in the height once he was taken off ventilator and he was started on activated vitamin. So this was the latest follow-up. Subsequently, the calcium increased to 7.5. Alkaline phosphatase started coming down. About a year down the line, alkaline phosphatase had slowly come down. He was taken off hydrochlorothiazide. The calcium dose was reduced to 550 mg per day, and he was on alpha calcidol 4 times a day. The improvement was steady, in between interspersed with periods of non-compliance with medication and the phosphorus going down. And then subsequently, he was lost to follow-up for almost a decade because he had a younger brother who had a hematological disorder. And he has come back to me for a review just 10 days ago. And now, after almost a decade, he's perfectly normal, going to school with a calcium of 7.3, phosphorus of 4, and alkaline phosphatase of 172 units per liter. And his treatment has now been, he has some amount of short stature, height is around 10 cm, but there's been marked improvement and no further hospitalization. So this brings us to the question, why was this child actually, now that he has come in and genetics are easy, he has also been sent for genetics. This brings us to the question, was this a case of vitamin D dependent rickets type 1 or type 2? The points against vitamin D dependent rickets type 1 are the fact that he did not have a very good response to activated vitamin D or calcium. The points in favor of VDDR2 was the fact that he responded to mega doses of vitamin D and calcium. He responded to mega doses of calcium and vitamin D being taken off BiPAP. He did not have alopecia, which is seen in VDDR2, but it's not mandatory that alopecia be seen in all cases of vitamin D dependent rickets type 2. Some of those cases might have a partial response, especially the subtype VDDR2 might not have alopecia. And secondarily, activated vitamin D is always high in VDDR2, but in rare cases, especially in people with a chronic disease, the activated vitamin D might not be very elevated. It might even be low or low normal. Secondarily, in case of any hepatic involvement, and we've seen that this child had hepatomegaly because of congestion, because of infection and repeated ventilation. In that scenario also, the activated vitamin D levels may be low because the conversion is impaired. So we should go ahead with the assumption that we are looking at a case of VDDR2, and given the response, it is almost certain that we are looking at a case of VDDR2, but a month down the line, probably the genetics will confirm it for us. And vitamin D is well implicated in lung disease, especially 125 hydroxy vitamin D alters the balance of the activated cytokines, and that is why many studies actually in asthma, COPD, and tuberculosis, supplementation of vitamin D is done. Even in cancers, lung cancer, low levels are associated with greater cancer incidence. And that is why there is a causal association between interstitial lung disease and low levels of vitamin D, be it of VDD or rickets or nutritional vitamin D deficiency. Coming to the second case, a child with multiple skeletal deformities. A 5-year-old who presented for evaluation of generalized bowing and deformity of both upper and lower limbs. He was a 5-year-old who presented with generalized bowing of limbs, kyphosis, and scoliosis. The skeletal deformities were noticed since birth. He was born of a 3rd-degree consanguineous marriage, only child of his parents. Antenatal history was normal. No history suggestive of decreased fetal movements. The reason why I asked this in the history, I'll connect it up later. Full-term normal vaginal delivery with a birth weight of 2.7 kilos. No history of birth asphyxia. No neonatal seizures or jaundice. And the deformities of limbs was noticed since birth. He had one episode of fracture of right wrist at 1 month of age when the mother tried to correct the wrist deformity. The subsequent healing was normal. The bowing became more prominent with age and was associated with a short stature. Did not give any history of chronic liver or renal disease or malabsorption. He was given 1 course of IM and oral vitamin D each, but with no improvement. Did not give any history of polyuria or polydipsia. No history of hearing or vision loss. No history of decreased sun exposure. No history of use of anti-tubercular drugs or anti-epileptic drugs. And no history of tetany or carpopedal spasms. On examination, the child is conscious. Height is 96 centimeters, less than 3rd centile for age. Height age is 3 years. Weight is 20 kilos, 25th centile. The weight age is 4 years. The mid-parental height is 165 centimeters, corresponding to the 25th centile, with a standard deviation score of -3 for the height, and is prepubertal. Examination, he had genovalgum, pectus carinatum, scoliosis. Did not have any evidence of wrist widening, rachitic rosary, or halisum sulcus. No alopecia, normal dentition, and no malunited fractures. Chopsticks and Trousseau signs were negative. Sclera was normal. The other systems were normal, and the IQ was age appropriate. You can have a look at the child. You can classically see the deformities. He has a genovalgum. He has a pectus carinatum. Some amount of scoliosis is seen. And he has severe short stature. No evidence of alopecia. To summarize, a 5-year-old with short stature, generalized skeletal deformities, genovalgum, pectus carinatum, and 1 episode of fracture. No gross evidence of hypocalcemia. So we went ahead with a diagnosis of nutritional rickets, which seemed unlikely. BDDR, which is always a possibility. Renal osteodystrophy. Osteogenesis imperfecta actually headlined the main differential diagnosis given the clinical picture. It's not mandatory that everybody should have a blue sclera, especially in types 3 and 4. Juvenile Paget should also be considered, though it's unlikely. Hereditary hypophosphatasia can present with this kind of picture. But the good fracture healing, which was seen in hereditary hypophosphatasia, kind of rules out this presentation. And Brugg syndrome is a rare disorder which can present with features similar to osteogenesis imperfecta with contractures, which is a connective tissue disorder. And on evaluation, the calcium was 9.6, albumin was 4.1, corrected calcium was 9.52, phosphorus was normal, alk-phos and magnesium were normal, creatinine was normal, urea was normal, and vitamin D was almost normal. So this rules out our diagnosis of nutritional rickets, rules out our diagnosis of VDDR, rules out renal osteodystrophy, normal alk-phos rules out juvenile Paget. Hereditary phosphatasia and Brugg syndrome are also kind of unlikely. But if you actually look at the differential diagnosis, nutritional rickets, it is not common to be deformities are not seen at birth. And because the calcium was normal, it's unlikely that they'll be dealing with nutritional rickets. Even though we have consanguinity, BDDR1 and BDDR2 are typically not presenting with this kind of picture, and a normal calcium excluded the clinical picture. Normal creatinine excluded renal osteodystrophy. Most of the time, this actually fit very well into an osteogenesis imperfecta. It's not mandatory that every case should have frequent fractures. Absence of a high alkaline phosphatase ruled out a juvenile Paget. It mimics osteogenesis, but features were not there. Bone pain was not very marked, and we didn't have a skull thickening. Hypophosphatasia had early tooth loss and poor fracture healing, which were not seen in this case. Brugg syndrome is somewhat similar to osteogenesis with defective collagen cross-linking, but it has congenital joint contractures. But contractures, as you can see in the pictures, were not in this child, so it was excluded. And we went ahead with a working diagnosis of osteogenesis imperfecta. Then we went ahead with a skeletal survey. You can actually see that there are vermian bones on the X-ray. You can see bowing of the bones. You can see a significant amount of osteopenia. You had a generalized mild osteoporosis, vermian bones noted posteriorly, a small sella, deformed slender ribs bilaterally, tapering ribs, the classic tapering ribs which are seen in osteogenesis, a long slender humeral diaphysis, anterior bowing of bilateral tibia and fibula, which you can see here. Grade 1 spondylolisthesis, L5 over S1. Most likely we were dealing with osteogenesis imperfecta. Those days I had the good fortune of taking radiological advice from Professor Kakal Subbarao sir. This was his conclusion regarding the case because genetics were not widely available. And he was considered the best skeletal radiologist in the world at that time. His conclusion was that from the radiology was that you're looking at a case of osteogenesis imperfecta type 4. But he suggested that we go ahead with genetics. So after the genetics could be done by either doing the confirmation could be done either by genetics, bone biopsy or histomorphometry, which is not classically done, or doing a bone densitometry. But densitometry in 2015 and 16, the Z-score and T-scores were not very well validated for Indian children. Actually, one pilot project was going on in NIN. We did it Z-score, but it gave us a score of 2, which was not correlating with the clinical picture because he had clear osteoporosis. Then we finally got the genetics done at Shiner in Ottawa. And this was the final result which they got with this. the sequence analysis actually showed that the child was homozygous for COL1A1 gene, and the mother and the father were both heterozygous for the same gene. If you can actually look at the cascade screening of the mother, father, and the child, all three had a defect in the same gene. They came from a consanguineous family. The parents were cousins. Both were heterozygous. Though it was considered a variant of unknown significance, given the clinical features which were correlating very well with this case, they actually said that it was in all probability a variant which was most likely pathogenic. The next question we had were we looking at a case of type 3 versus type 4? Most of the mutations actually in collagen gene show dominant type, but this showed a recessive inheritance, which has been reported, though this particular variant has never been reported till date. The homozygous variant predicted to destabilize the collagen triple helix. The phenotype is generally moderate to severe. It is non-lethal. That was why we did not have decreased fetal movements in the child intrauterine. He did not have any intrauterine fractures. Likely type 3 because he had progressive deformities. Type 4 is also a possibility, but more number of fractures are seen in type 4 because since we had only one fracture, in all probability, we are looking at type 3. The treatment options for this, the mainstay remains bisphosphonates, either pamidronate or zoledronic acid, which is given in the dose of 0.05 mg per kg once every 3 months. Teriparatide can be tried in mild to moderate adult osteogenesis imperfecta, but bisphosphonates remain the mainstay. Denosumab is still investigational. Vitamin D and calcium supplementation has to continue. You need to have orthopedic interventions and splinting and rods for long bones and spinal stabilization when he has spondylolisthesis. Physiotherapy is required and immobilization should be avoided because you'll have immobilization osteoporosis. And hydrotherapy or aquatherapy is also considered in these patients, not widely done. Novel agents like romosozumab, anti-transforming growth factor beta antibodies, stem cell therapies have also been tried. The current strategies are CRISPR or Cas9 editing, which are gene-based strategies, but the stability of the genome is affected by CRISPR. We are still in the early stages of CRISPR. And because dental anomalies can happen later on in life, we need dental and hearing care and psychosocial counseling. These are the clinical features of the various types of osteogenesis imperfecta. Type 1 is mild, but you'll have a blue sclera. Type 2 is lethal in the perinatal period. 3 is usually deformities present since birth. Scleral hue might lighten with age. Type 4, mild to moderate bone deformities. Type 5 is histologically indistinguishable from type 4. Type 6 is again pretty similar to type 4. Fish scale appearance of the bone under the microscope, but we generally do not do any biopsies of the bone. 7, 8, and 9 are very rare. So even though these are reported as autosomal dominant or recessive, just go back. Even though for all practical purposes, 1, 2, 3, 4 are reported as autosomal dominant, we can have a few autosomal recessive variants. Variants 7, 8, and 9 are generally autosomal recessive. The complications which we generally get are hearing loss manifested by the early 20s. The common cause of mortality is cardiopulmonary because of compression of the lungs and the heart. Neurological, you can have macrocephaly and basilar invagination. Short stature is very common, and recurrent fractures and deformities are usually seen in a majority of cases of osteogenesis imperfecta. With this, I come to the end of the presentation, and if you got any questions, I'd like to take them.
Dr. Andressa, please.
Sir, that was an enlightening presentation on 2 very rare cases, which was worked up quite beautifully. And we would like to thank you for the session. In the chat box,
I don't think we have any.
No questions are there, sir.
Yeah, we will get some questions to the. Maybe I'll request to maybe join.
I'll be there. I'll be on here. I'll keep my mic and video off. If there are any questions, I'll join you at the end of the session.
Sure, sir. Thank you, sir. We'll inform you also.
Right.
Next upon, I would like to invite Dr. Om Lakhani, sir, consultant endocrinologist, Sidus Hospital, Ahmedabad, who is presenting a topic on bone health, biomarkers, and fracture risk assessment. Sir is a winner of President's Gold Medal, Taisa A.V. Gandhi, and various awards to his credit. So he's also the founder of Technocrinology, an upcoming artificial intelligence and endocrinology integrating platform, which is useful to all the upcoming and the current practicing endocrinologists in many forms. So once again, I would like to invite Dr. Om J. Lakhani to the stage to present the topic.
Thank you so much, Andresa, and thank you to Dr. Mohan, and thank you to Hari sir, for having me for this. Thank you to Lakshmi Nagendra also from the Skeletal Task Force as well. So please allow me to share my slide.
You can try.
Just give me 1 second. Yeah, is my screen visible?
Yes, perfect. Go ahead. Go ahead.
Perfect. Okay, sure. Thank you. So once again, let me thank the organizers and thank you to Endocrine Society of India, Dr. Kaushik Pandit sir and Dr. Hari sir for having me for this. Well, let me first say before I begin that I had exactly 24 hours to prepare for this. Originally this talk was for Dr. Kaushik Biswas, but he could not join because of some health reasons. So I have taken a lot of liberties and inspiration from some slides from his presentation, which I've incorporated into mine. Bone turnover marker, even when I was a student, used to give me nightmares to present it in front of elite endocrinologists. I had, basically nightmares the whole night. But having said that, I'll try to do my best. And my idea is to try to make it as simple as possible and as easy as possible for you to understand. Now, the first thing I did when I was asked to talk on this topic was to really, and I'll tell you a backstory to this. So we actually, we are very confused about bone turnover markers when we are practicing this is about 7 or 8 years back when we actually started our practice. So a bunch of all young endos from Gujarat, we all got together and we said that, what should we do about trying to understand bone turnover markers. So somebody told us that the best person to learn bone turnover markers is Dr. Thomas Paul, sir. So what we did was, that time we wanted him to come to Ahmedabad, but because of some logistic reasons, he could not travel. So we actually arranged a webinar, something like this, for us to basically learn about bone turnover markers from Thomas Paul, sir. And sir taught something which I still remember. It was outstanding. And I don't know if sir is still there. And sir, I don't know if sir still remembers. But so what I did, last night was basically to go back and listen to the talk. We had the recorded, just like Dr. Sri Nagesh sir has all the, archives of the best cases that he has. We have archives of some of the best, presentations that we have listened to. And we went back to that. I listened to that talk. So whatever I'm going to tell you, is what I learned from Dr. Thomas Paul. Basically hats off to him, because a lot of the work which you see is from, CMC fellow Dr. Sahana, Dr. Nitin Kapoor, and Dr. Thomas Paul sir's work. So let me first start with this, right? A very fundamental point, which management guru Peter Drucker always says: what gets measured gets managed. Now, one of the biggest challenges of osteoporosis management is actually you are basically doing a DEXA scan every few years, right? But unfortunately, that the measurement of the same and how you interpret that often varies. And neither the patient and a lot of times not even the doctor is very confident about interpreting a serial DEXA. Also, we do not know. There are a lot of variations there. Now, if you compare that to another chronic disease, which is diabetes, what we see is diabetes gets managed much better because of the fact that you have better means of measuring the disease. You have HbA1cs, you have blood glucose values, now you have CGM also, right? So because you measure it better, you tend to get more focus, you are more involved in it, your patient has more compliance with the care. Whereas if you compare that with osteoporosis, the challenge is because the measurement tools are not that, not that perfect, the measurement often gets lagged behind. And because of that, the management also kind of lags behind. The patient is not that involved in the care of an osteoporosis as they are as they are involved in diabetes care. So I think that is the major thing. And that is where bone turnover markers are very useful, because they solve this problem. It's again a blood test, just like the other blood tests which your patients do. And with that, the patient is able to actually understand the progress. The clinician is able to understand the progress, and in some cases also modify the treatment based on the thing, right? So this is the outline for my talk today. I'm going to introduce bone turnover markers to you. We are going to see the clinical use cases for bone turnover markers, and then I'll give you some practical tips, what I have learned in my practice and what I learned from Dr. Thomas Paulser. So that is what we are going to do in today's talk. So let's start with understanding bone turnover markers. Now, to this elite audience, the bone remodeling cycle is very well known. I don't have to tell you this. In fact, you will probably tell me, right? So the bone turnover markers is, the bone remodeling cycle is very well known. What we know essentially, what we need to understand, and for the audience who are not endocrinologists, what I'll say is, what we basically need to understand is that the bone formation and bone breakdown are linked together. They are married together. They move together. So whenever you have bone formation, you have bone breakdown. When you have bone breakdown, and when you have bone formation. So it's a well-made system. Sometimes this system breaks down, so you have more bone formation and less breakdown, which is rare. But you have more breakdown and less formation, which is common, right? So that is what we typically see in a lot of situations, and that is basically leads to a lot of pathological issues. So the simple idea is that you have certain tests which are certain ways in which you measure bone formation. So you either measure the bone formation or you measure the bone breakdown. In most cases, both the things happen in parallel. In certain situations, there might be some sort of a discongruence to it. So sometimes there might be less formation and more breakdown, and vice versa. So with bone turnover markers, you are measuring either the bone formation, bone breakdown, or both, and then you are interpreting the whole thing in context of the clinical situation of the patient. Okay. So in that context, if you see a DEXA, so I would just compare this in the same way as you do as an HbA1c and a CGM. So an HbA1c gives you a static picture. Same way, a DEXA scan gives you a static picture of the patient's bone situation. You did a DEXA, you repeated the same after 1 year, maybe after a couple of years. So you're getting a static picture of what is happening at this point of time. Whereas a bone turnover marker, because you measure it more frequently, you are getting a dynamic picture of the things that are happening, how the patient is responding to your treatment, whether the patient is compliant with the treatment, and so on and so forth. So that's why bone turnover markers play a key critical role in the management of osteoporosis, because they give you a more current and hands down and more dynamic picture of the process which is ongoing. Now, I told you there are bone formation markers and there are bone resorption markers. So bone formation markers, you have P1NP, which is the most popular, and the bone resorption marker, you have CTX, you have NTX, and you have TRAP5B. So you have this three classical bone resorption marker. Bone specific alkaline phosphatase is another popular bone formation marker, and osteocalcin is another popular bone formation marker. So as you can see from this simple slide, that you have certain markers which are bone formation and certain markers which are bone resorption. Now, always remember this. So again, if you put it in context of what I showed you in the earlier slide, bone turnover markers are not to be interpreted in isolation. They are not substitute to a bone density. They are complementary to bone density. Just like, for example, a CGM is not a substitute to an HbA1c. It's complementary to HbA1c. So you will do HbA1c to get the big picture and the risk of complications, and you will do CGM to look at the nitty-gritties of the diabetes management. So where would you like to add another anti-diabetic agent? Which are the problem areas? Which are the situations where the patient is hypoglycemia and hyperglycemia? In the same way, with a bone turnover marker, what you're doing is you are looking at the current ongoing situation, whereas you are with the DEXA or a BMD DEXA, you are getting the whole picture, you are getting the big picture in the patient situation. So this is how you basically would look at bone turnover marker vis-a-vis a DEXA. So now this is one thing which literally changed my clinical practice when I listened to Dr. Thomas Paulser. And what Dr. Thomas Paulser told us, that you don't have to worry about so many bone turnover markers, right? There are so many of them. There are, there are again different values to that. There are different pre-analytical issues with bone turnover markers. What you need to do is you just need to focus on two: one bone formation marker, one bone resorption marker. The one which are standard of care and which most of the international consensus guidelines suggest is you have to measure just two and measure and monitor just two of them. For bone formation, you use serum P1NP, and for bone resorption, you measure the serum CTX, right, which is the also known as beta cross slabs. So basically, and my rest of my talk is going to be focused on these two markers. So we'll be looking at, from the bone formation perspective, of P1NP, and a CTX from the serum CTX from the bone resorption marker. Now, there are certain urinary bone resorption markers also. Let's not confuse the matters. We will just focus on, and again, my idea is to simplify things. We'll just focus on these two bone markers, the serum P1NP and CTX. And if we will do all the rest of our understanding and interpretation based on these two markers. Now, some alternative, we have bone-specific alkaline phosphatase, which is a good marker, especially patients with CKD. And if you want to see TRAP5B, again, a good marker for CKD patients. So these are special use cases, but in most cases, you will be using one of these two. Now, just like any other tests, well, bone formation markers or bone turnover markers are very fickle. There are a lot of issues with, just like any other endocrine test. You will have to do it in the morning as a morning collection in a fasting septal after an overnight fast. Generally, there are circadian issues also. So you have to measure it at a particular time. Again, there could be serial measurements which would lead to changes. And then again, there is some bit of patient preparation also required. The patient has to avoid vigorous exercise, and again, especially for 24 hours prior to collection. So there could be, again, pre-analytical issues with interpretation of the results. And again, you have to interpret the results based on the clinical context of the patient and not just in isolation. Especially now, serum CTX is definitely affected by multiple factors. Like I said, there is a circadian rhythm. There's a circadian variation. Again, food intake will lead to reduction of the CTX values. Same with glucose status. So especially in uncontrolled diabetes also, there could be slightly lower serum CTX values. And renal failure also will lead to misinterpretation of the CTX. So always remember that whenever, just like any other endocrine test, whenever you're measuring these tests, you have to measure it in the context of the clinical situation which the patient is having. Also, additionally, there are population-specific reference ranges which are required. Again, all these bone turnover markers will be affected by genetic factors. They'll be affected by environmental factors, including vitamin D status, a lot of the dietary and lifestyle patterns also. And again, there are ethnicity-based issues also. So again, there are ethnicity-based VTM ranges also, which is available. For more on this, I'll introduce you to a very, an excellent, and this is what I read last night, an excellent review article by Dr. Sahana, along with Dr. Thomas Paul and Dr. Nitin Kapoor. They wrote this paper. It is published in Indian Journal of Endocrinology and Metabolism in 2016. So, or Clinical Endocrinology in 2016. So that is the paper I would suggest you should consider reading on this particular topic. Having said that, there is an article published in 2023 by Dr. Vasikaran, where this is an Asian consensus statement on the normative values for these two essential bone turnover markers. And these are the values which they've suggested, and I'll suggest that that is what we'll use as a normal reference range. So P1NP values of 15 to 70 microgram per liter, and beta cross-slabs, that is the CTX, you'll have 100 to 700 nanogram per liter. Just be careful about the units because in certain areas, the units may differ. Okay, so now let's come to the clinical use case. So this was the introduction to the bone turnover markers, the basic introduction. Now we'll see how you'll use bone turnover markers in your own clinical practice and how you can interpret the results based on the clinical practice. Now, the first use case, which is very intuitive, is to use bone turnover marker as a third umpire. So in situations where you're not sure whether to treat a patient for osteoporosis or not treat, bone turnover markers can be that extra element, can be that extra third umpire, which will help you unravel and decide whether you want to treat or not. Now, let me give you a clinical case scenario. And again, let me just say that all the clinical vignettes are actually given to me by Dr. Kaushik Biswas. So I've taken this clinical vignette straight, copied and pasted from his slides. So if you have any specific queries regarding the cases, please contact Dr. Kaushik. I'm going to just basically represent or re-represent the cases which he has said. So he has a very beautiful case which illustrates this point beautifully. So we had this 62-year-old female patient who came for evaluation. Now she basically had an osteopenia, and she had on her BMD, she had a T-score of minus 2.1. The indices basically showed reduced bone mineral density. They also did a FRAX, and they calculated the FRAX, and again the FRAX risk was 5.5% for major osteoporotic fracture for a 10-year risk probability. Again, does not come in the classical range where you should consider treating, right? So in this case, you are now in the dilemma or whether to treat or not to treat, right? So you are in this situation. Now, this is where in such situations, the bone turnover markers can be very useful. So what Dr. Kaushik did, that he measured the CTX value, and he measured the CTX value, it came out to be 1.45 with a normal range of less than 1.01. Again, remember, like I said, it will be 145 nanogram per liter. So just be careful about the units. Now the values are actually higher. So what this tells us is that the patient is having more bone breakdown. And in that situation, your tendency towards treatment increases. So you are probably then considering to treat, right? So your error in the side would be to treating rather than not treating. So in that case, in this situation, Dr. Kaushik Biswas decided that this patient should be treated. Just that you're not very sure, but this turned out to be a sort of a little bit of a third umpire for you to consider, or an additional parameter to consider for treatment. Now, you will then tell me that, Om, is this clinically validated? Actually, there are a large number of studies which have actually looked at addition of bone turnover markers to the existing evaluation parameters for treatment of osteoporosis. And for example, this is a study by Dr. Garnero, which looked at combining the hip BMD along with CTX, and what they found was that you had a better fracture predictability with combining these two parameters instead of trying to interpret these two parameters in isolation, which is again very intuitive and again easy to understand. But having said that, this one study which was very impressive was by Jonel back in 2002 by in Osteoporosis International. Remember, just like you have some of the elite journals like Diabetes Care for Diabetes, you have Osteoporosis International, which is the elite journal for osteoporosis. And in this, basically, they simulated a hip fracture risk probability based on various combinations of risk factor parameters. And what they found was this one, right? So urinary CTX with a prior history of a fracture is the strongest marker of a future risk factor for hip fracture. Again, of course, a prior fracture definitely will tilt the equation towards it. But secondly, and the parameter which I think would be more useful in a primary prevention cohort would be a BMD with a urinary CTX, or in our case, of course, a serum CTX would be a good marker, a second best marker for predicting the risk of a future hip fracture. And then you look at BMD with a prior risk fracture, prior hip fracture, and then or a prior fracture, and a urinary CTX with a prior / a prior fracture. So again, they have combined this, and you can see where BMD really comes. It comes way bottom into the equation, right? So all these things, so all these situations where you are combining two parameters, risk parameters, you're getting a better answer. Well, this type of model in 2002 is ripe for being evaluated with a machine learning AI-based model, right? Perfect. If you just get this data, you could actually reevaluate this data and perfectly with AI, and you will get much better insights in terms of the predictability. But having said that, the idea, even with this simple, elegant paper, is that what I'm trying to put to your mind is that adding a bone turnover marker in the risk evaluation does add more value to the predictive power, and hence it should be considered in these situations like where you are not very sure whether to treat or not to treat. Now, more important than starting treatment or not, it's more important to really use bone turnover markers for monitoring response to therapy and adherence to therapy. So I think this is a more useful use case for bone turnover markers. I think this is again an area where you have a wide gap. You have an area of need, and this area of need is actually fulfilled by bone turnover marker. Again, so just to give you a very simple simulation to understand, let's say you are following up a patient by doing a serial BMD DEXA. Then what you'll be doing is typically you'll get a more reasonable value at 2 years, right? So at 0.0, you started the patient on treatment, and then at end of 2 years, either the patient gets better or the patient gets worse. You'll only know at the end of 2 years. So you already lost a bunch of time in that regards. However, with a bone turnover marker, within 3 months itself, you will get some idea of where the patient is heading, whether the patient is heading in the right direction, or whether you need to optimize the treatment, or whether you need to reinforce adherence to treatment, right? So that's why you get much early a prediction of how the patient or where the patient is going, instead of waiting for 2 years for really getting the whole picture, right? So I think that's why bone turnover markers, and again, very elegantly shown by this simple slide, tells you that bone turnover markers gives you a early idea of where the patient is headed towards, and then hence you can then course correct or see whether you're going in the right direction. So typically, again, a rule of thumb is something like this, that whenever you initially start, you do a baseline CTX and P1NP, and typically the bone breakdown markers, that is the bone resorption markers, typically normalize in about 3 to 6 months, but a bone formation marker will generally take a slightly longer time, that is 6 to 9 months to normalize. So this is the typical path you will understand. And then what kind of change in the value would you consider to be good? So basically, you should consider, in the least significant change, that you should consider 30% change in the CTX value, or 20% change in the P1NP value to get the actual picture of where the patient is headed towards to. Now, this is a very important and fundamental point. Remember, the type of therapy will also determine your response to the bone turnover markers. So I think this is again it's intuitive to understand, but just to reinforce this point very strongly, when the patient is on an anti-resorptive agent like a denosumab or a bisphosphonate, then it will suppress the bone turnover markers. So you'll have a reduction of P1NP and CTX value. Whereas if the patient is on a teriparatide, there'll be an elevation of P1NP value, which is what you're monitoring. And this is elegantly shown by this picture, this cartoon here, where basically the patient initially is on a teriparatide. You can see there is an increase of P1NP, increase of bone formation, and also the a little bit of increase of NTX. Also remember, a teriparatide will increase the bone turnover, whereas when the patient is on an alendronate, what you are seeing is this. You are basically seeing that there is a suppression of these bone turnover markers. So that is what you should keep in mind, that the type of therapy which the patient is on is very, very important to use that. Again, if the patient is on an anti-resorptive therapy, your idea again, what therapeutic goal would be to suppress CTX to value of less than 0.3 or P1NP to a value less than 35. So that is what we'll be looking for in terms of the therapy. And again, if the patient is on a bone anabolic therapy, within 1 to 3 months, you will expect a good response to therapy would be an increase of P1NP by greater than 10 microgram per liter. So that is what you're looking at. So remember this slide again. So P1NP increase of more than 10 is considered a good response to therapy. Whereas if it doesn't increase, then you are probably looking at maybe adherence issues, or there could be, again, in terms of, there could be other factors also, maybe the injection technique, storage errors, poor adherence, and so on and so forth, right? So that is what you'll see. Now, $1 million question is, how does it really work with romosozumab? Remember, romosozumab has a dual sort of action. It is anti-resorptive as well as a bone anabolic. And what you will see is, what you see on the top, on the dashes, with the dashes, this is P1NP, and what you see in the bottom is the CTX. So there is a dual response here as well. So initially, with a patient on romosozumab, there is a transient increase of P1NP, and then P1NP reduces and it gets suppressed. And CTX, there is a transient drop in the CTX value. Then again, it comes back and then it keeps dropping, right? So it keeps being suppressed. So when you finish the treatment after 1 year, typically both the values will be suppressed. But P1NP, there'll be a transient increase, which you have to keep in mind when you are interpreting the results in the light of the clinical parameters. So again, with romosozumab, you should be aware of these clinical parameters. Another useful thing, and this again I learned completely from, and I had no idea before I read his paper, and before I interacted with Dr. Thomas Paul. This is something which he taught me, which I still remember and still, in fact, use in clinical practice also. A bone turnover marker could be very useful for actually guiding what kind of therapy you should consider. So baseline bone turnover marker, and if you find that the P1NP and CTX both are increased, so you have both increase of bone formation as well as the bone breakdown marker, that basically shows that you have high turnover. And then in such cases, you should probably consider using an anti-resorptive, right? So you have increased turnover, and then you want to suppress that. So that is what you should consider doing. On the other hand, if you have both the things decrease, so you have P1NP which is reduced, and the anti-resorptive is either, again, the resorption markers are either reduced or normal. In that case, you have a sort of a hypodynamic state of the bone, some sort of adynamic state, and in that case, a bone anabolic agent would be a better choice. And then when you have this flipped thing, where you have the bone formation marker which is reduced and bone resorption marker which is increased, then in such situations you can consider either of the therapy, but you first consider giving a bone anabolic and then anti-resorptive, right? So this type of dual therapy would be useful. So you can actually use this therapy, the bone turnover marker, to really guide the form of therapy which you want to give. And I actually use this, especially useful in situations where you're not very sure of which therapy to give for osteoporosis in this case. Now, another very useful use case, again, explorative, but could be potentially very useful, is to help you in diagnosis of a secondary cause of osteoporosis. Now, again, what people have seen is that the molecular signature, so whether it's the biochemical signature, that is, what kind of, there is a differential in terms of bone formation and bone resorption, you could actually get some sort of a differential diagnosis in terms of the metabolic bone disease. Additionally, if the bone turnover markers are very high, especially the bone resorption markers are high, you could probably then look at potential secondary cause of osteoporosis rather than just depend on primary osteoporosis. So that is, again, a very useful thing. In fact, this is a expert recommendation from Dr. Kaushik Biswas. Like I said, originally slides, some of the original presentation was made by him. What he has very categorically stated is that baseline resorptive marker is a clue for you to look for secondary cause of osteoporosis. Again, this is the expert opinion. This is not a clinical recommendation. Again, to give you an example to illustrate this, this is a case which he has shown. So this 54-year-old female actually came with osteoporosis, and on face value, things look pretty much okay. But what what Dr. Kaushik thought was, in terms of digging deeper, is that he found that the serum beta cross level, the CTX values were very high. So you can see, almost 380, right? So pretty high, 3 times the upper limit. In which case, what he's then thinking is that probably this is not a routine case of osteoporosis. Remember, this lady is also just 54 years old. And then they dug deeper, they looked at the secondary cause, and they found that the patient actually had celiac disease. So I think, again, testimony to the fact that when you have something not fitting into the equation, you could probably look at this in a light. And again, from this slide, you can really see that sometimes the the biochemical signature of the bone turnover markers can give you a hint towards a diagnosis. And let me point out to you one typical situation. You see this with multiple myeloma. So you have increase of bone resorption marker and reduction of bone formation marker. So again, you should, if you have such a situation with possibly a hypercalcemia, well, why not look at multiple myeloma as a cause? And very interestingly, diabetic bone disease has a reduction of both, right? So again, you have reduced bone formation as well as bone resorption markers. They are on the lower end. Well, that makes me think, why not consider teriparatide as a standard of therapy in diabetic patients with osteoporosis? Again, with glucocorticoid therapy, there'll be a flip ratio, so there'll be increased bone formation, bone resorption, and reduced bone formation marker. So again, what I'm trying to tell you is that based on the biochemical signature, you may be able to make a certain clinical diagnosis. It will hint towards a certain. It's not that it's going to make you the diagnosis. It will hint towards a particular diagnosis. Again, this could be useful in clinical practice. Finally, one important use case which all of us, of course, not many of us use it, but it could be something which could be useful once we start giving drug holidays to patients on bisphosphonates. What you could do is that the bone turnover markers could actually be very useful in monitoring the patient during the drug holiday. So let's say, you started the patient on zoledronate, and after 3 years, you give the patient a drug holiday. Then what you do is you serially measure the bone turnover markers. And if the P1NP starts increasing, right, or if the CTX value starts increasing, at that point of time, you should probably consider discontinuing the drug holiday. And if the patient continues to have suppressed values, then you can probably continue the treatment, continue the patient on drug holiday, right? So this could be a good guide towards when to restart treatment or whether to restart treatment at all in such situations. Again, with a margin of safety. Remember, what you're doing is you are then also preventing some sort of a adynamic bone disease and fragility fracture and atypical femur fracture by doing in this manner, right? So by actually looking at where we are going. Remember, the adynamic bone disease is a situation where you have atypical femur fractures, and by monitoring in this manner, we are actually preventing this from happening. So again, this is again a little bit of an insight which you could look at, right? So finally, the last few slides, practical tips and tricks, and how I typically tend to use bone turnover markers in my own clinical practice. So first thing I'll say is, before you start osteoporosis treatment, and if your patient can afford it, and if your labs have this available, you should definitely consider doing bone turnover markers. Just do 2 tests, P1NP and your CTX. First of all, it will help you decide whether to treat or not to treat, especially in cases where you require some sort of a referee. Again, it will help you decide what kind of agent you should consider for treatment. So what would be a choice of agent? It will help you give you a baseline value, which you could use for monitoring therapy. So again, if you want to look at the compliance of the patient, you could look at that. And then you could potentially rule out secondary causes, especially if the values are abnormal or very high, the bone resorption markers. You could probably then dig deeper to look at a secondary cause. And again, once you have started treatment, how does bone turnover marker really help you? It helps you monitor response to therapy. It helps you monitor adherence to treatment. And again, it could, especially if the patient is on a drug holiday, it could potentially, you could decide when to end the drug holiday for patients on bisphosphonate. So finally, and this is what I'll end up by saying, I showed you the use cases. I showed you different ways in which you could use bone turnover marker. But I often feel, and this is my little take, is that bone turnover markers are actually very delightful. A lot of research use cases. It's a key. We know that there is something there, but it's a key trying to find its perfect lock, right? So that is what I'll see. The exact use case, we are still not narrowed down. This is exactly where you use bone turnover marker. It's left to a creative freedom, and it left to clinicians and researchers. Overall a situation of where they want to use it. Definitely useful in research, but in clinical practice, we are still trying to find that perfect lock. So that's what I'll end with. Thank you. And once again, thank you to Endocrine Society of India for giving me this opportunity for this talk. Thank you.
Thank you, Dr. Omjay Lakhani, for delivering such a wonderful talk and stepping in at the last moment. And we also would like to thank Dr. Kaushik Bishwa sir for the slides and the presentation. And next, I would like to invite Dr. Umesh Kumar Garg sir, Dr. Ipsida, Dr. Ramesh, Dr. Shinjan Patra to deliver the talk on osteocrinology, research and collaboration along with patient guidance. Dr. Umesh Kumar Garg sir already been introduced by Dr. Mohan Shanai sir. And Dr. Ipsida I would like to introduce, and she's a senior consultant endocrinologist in some hospitals. She has multiple publications and various awards to her credit. Dr. Ramesh is an assistant professor in PGI Chandigarh. He has received Young Investigator Award, AR Seth Award, and multiple ESI awards. He also has more than 180 publications to his name. So I would like to invite Dr. Ramesh Pal and Dr. Ipsida to the stage. Next is Dr. Shinjan Patra. He is an assistant professor in AIMS Kalyani who has received the Endocrinology Award and also has multiple international and national awards to his name. He is also a reviewer of IJDCC Journal. Welcome Umesh Kumar Garg sir and team to deliver the session.
Thank you, Antrisa.
So, do you have any slides, Umesh?
Yeah, thank you, Antrisa. So this is a panel discussion. With me, we have three eminent experts, Dr. Ramesh Pal from Chandigarh, Dr. Shinjan from Kalyani, and Dr. Ipsita from Qatar. So we are taking cue from the first line of Thomas Paul sir and last line of Dr. Om Lakhani, where the first session started and it was closed. As Dr. Thomas Paul sir said, bone health actually starts from the childhood. It is seen by pediatrician to gynecologist, endocrinologist, orthopedician to geriatrician. This is what I often call bone health actually start from womb and it lasts till the top. My last clue was Dr. Om Lakhani has said that we have a key, but we have to find out the perfect lock for which research is required. So now talking about the bone. Bone is an endocrine organ now often being looked upon. So the endocrinology of bone, which we call osteocrinology. So there are two things. One is seen by every specialty and second is research. So taking the cue, our discussion will be on various aspects of osteocrinology, research, collaboration, and what are the guidance for the patient. So we have our eminent panel. To start with the Dr. Ramesh Pal, I would like to ask, as we have seen, a lot of specialty are having seen the patients of osteoporosis as well as the bone health. So osteocrinology is seen by many domains. So what are the practical domains where research, as Dr. Om said, is the requirement? So what are the practical domains of research in osteocrinology which actually can benefit from the research collaboration? So your view, Dr. Ramesh.
Okay, good evening. Good evening, everyone. Am I audible? I believe I'm audible.
Yeah, you are audible.
I'm audible, yeah. Good evening, everyone. Thank you, Dr. Umesh. Thank you, the Endocrine Society of India for making me a part of this webinar. See, yes, bone is definitely an endocrine organ, no doubt in it. But I would prefer not to use the term called osteocrinology. Actually, it's not a general, it's not a approved term. It's something that we should not be buzzing about. I mean, yeah, it's fine. I mean, I'll be more happy to talk about osteoporosis and related metabolic bone disorders, right? So, I mean, that's how, I mean, one should go rather than using a fancy term like an osteocrinology. Second is what about the you're talking about the domains of research, like what aspects of research that we can think of in the field of osteoporosis and metabolic bone disease. So, I mean, the first thing that I believe is that, I mean, for any research, for any strong clinical research, we need a strong data. So a research is as good as or rather as strong as the data behind it. So the first practical domain for collaboration would be for building robust national databases, what I feel. I mean, a good database would provide ample data for epidemiological research as well as clinical research as well. So in this regard, I would like to point out the fact that from our institute, we have 3 national registries: the Osteoporosis Registry of India, the Indian PHPD Registry. The Indian PHPD Registry dates back, I mean, it's more than a decade old, I believe, and the Rare MBD Registry. So we find, I mean, our centers are actively contributing to the registry, but it would be great if other centers contribute to the registry as well. So we need a pan India data. I mean, that would serve as a huge database and a huge raw material for subsequent robust research. Second, I feel is that something that something that we had been, doing since our DM days, is that generating pan India normative databases. Something that is very important. We are relying on Caucasian database. We are relying, the DEXA scanner that is generating a BMD T and a Z score that is based on a Caucasian female or a Caucasian male, enhanced database. But that doesn't hold good for the Indian setting. We do have some data on BMD from at least, I would say, from possibly from all 4 parts of the country. We have data from our center, from Delhi, from Lucknow, I believe, from South, from CMC Vellore, I believe, and from the West as well. We have not incorporated this data in the scanners. So we are still not able to generate T and Z scores based on our normative data. Second is normative data on another aspect of bone, which we often do not talk about, is muscle sarcopenia. Actually, we also need to generate reference database, normative data for muscle mass and muscle strength for defining sarcopenia in our population. Third, I feel that we need to work upon is pan India fracture liaison services. That is something that is lacking on a pan India basis. So that a fracture liaison service will not only improve patient care, but will also help generate significant amount of data for future research. Fourth, I believe, is something that, again, we have been working, but we have not been able to probably hit the nail, is that generation of a India specific fracs. So we are relying on, I think, Singapore Indian fracs, which might not be, it's not that applicable in our setting. Lastly, I feel, again, since we're talking about fracs, so apart from, people can think of generating some AI models for, AI driven fracture prediction models. Last 2 things which is very dear to me is diabetic bone disease. Yes, there is a lot of work from the West, but probably, since the fact that diabetes per se is something, the pattern of diabetes is something unique to India, we need to work more on diabetic bone disease in our country. And last is CKD-MBD. CKD-MBD is a mystery, I believe. Even, at least I feel it's a mystery to myself. We might have to, maybe on a collaborative basis, if we work on CKD-MBD, we might end up with some more meaningful data or meaningful conclusions. That is all I can recollect as of now.
Thank you, Ramesh. What I can understand is collaboration can be used to generate data by making registries. We can have also normative data for Indian population. We can use it for predictive tools like FRAX or AI model. We can enhance our clinical care by fracture liaison services. We can also increase the other domains, other comorbidities like diabetic bone disease and CKD-MBD.
That is entirely my perspective.
Please,
it's entirely my perspective.
However, we know that a lot of benefits are there, but it is not always a easy cakewalk. As Dr. Ramesh has said, there are a lot of things which need to be done. So my next question is to Dr. Shinjan. We know that there are the possible benefits, but what are the actually barriers for this research collaborations, whether it is inter-institutional for like PGI Chandigarh and CMC, or even a clinical basis, or even an interdepartmental or intercontinental, for some example, West and the India. So what are the barriers and how to overcome them? Over to you, Dr. Sinjan.
Yes, sir. Thank you, Umesh sir, for the kind introduction, and also thank you, Endocrine Society of India, Mohan sir, Lakshmi ma'am, for having me here. So obviously, as Ramesh sir has already said, our hot research areas for the osteoporosis related workup. But the most important thing which are actually lacking is the availability of DEXA in India. In a pan-India setting, especially in the tertiary care centers, we are mostly having the DEXAs, but having endocrinologists almost at every part, it's not very useful, or rather it will be more useful if we have more DEXA in the various centers which we lack currently. That's one of the most important barrier to have a collaborations, and having a various models of the DEXA in the various institutes is one of them. Even if we have the DEXA, if we have the software like the trabecular bone score or the vertebral fracture assessment, that is also not homogeneously present. It can be variable. We may have the TBS, like in our institute, we have the TBS software, but we are just getting the vertebral fracture assessment. So that's why we need to rely on the lateral view of the lumbar spine to assess any vertebral occult vertebral fractures. So this approach is, or the DEXA, the availability or the associated softwares are not uniform. Second is the availability, which Om Lakhani sir has nicely highlighted about the importance of bone turnover markers, as well as the evaluations of the secondary osteoporosis cases. Like PTH is one of the most important assessment in every cases of osteoporosis, where we can diagnose a case of primary hyperparathyroidism by seeing a case of fragility fractures. So what are the assays of PTH we are using? Are we using in our own lab? What is the method we are using the PTH? That is also important. As well as the bone turnover markers. Are we doing the bone turnover markers, or are we doing both the P1 and PCTX? Is that available in all the centers? So when we are collaborating, all these things come into our mind, and all these things has to be in sync. The availability of DEXA, the useful softwares, the evaluations, including the bone turnover markers or the other relevant investigations. So that is one of the area where we need to work on, and to formulate a project for a multicentric collaboration, especially on osteoporosis. These things are the most important, above which we will be formulating a project. So not having that uniformly in every institute is one of the most important barrier. But yes, fortunately, like the endocrinologists, especially like in our contemporary endocrinologists, we are very much interested in bone mineral health and learning from the very learned seniors. So we are trying to formulate this homogeneous systems or homogeneous infrastructure, and hopefully we can go ahead with that in the near future.
Thank you, Dr. Sinjan. So what I can understand is, one, lack of resources like DEXA software, and second is their homogenization, the same platform, whether it's a biochemical assays and all these are basically a big hurdle. We need to homogenize this. Having said so, okay, resources, we are planning for this, but whether it turn around in a ground reality of clinical care, we have seen pediatric cases, we have seen the importance of laboratory. So suppose we have these kind of collaboration between the clinicians, because as Dr. Nagesh has seen, 2 cases which are seen by pediatrician, pulmonologist, laboratory medicine, Dr. Om has said, we are seeing the also as with the pediatrician along with the orthopedician. So Dr. Ipsita, my point is, if we have a collaboration between endocrinologist, orthopedician, pediatrician, gynecologist, geriatrician, how this will help in the bridging of the care, the gap which is there in the care of the patient, how we can fill this gap with the collaboration. Over to you, Dr. Ipsita.
Thank you, Dr. Umesh. I thank Dr. Mohan, Lakshmi, and the Endocrine Society for giving me this opportunity. I think this question is an extension of what was put up to Shinjan. This is rather, I feel that it is a very important methodology in which we can overcome the barrier which is existing to management of bone health disorders. See, most of the institutes, the collaboration between these fraternities that you have put up in the question, orthopedician, pediatrician, gynecologist, that collaboration does not exist in almost all of the institutes. So, and we have discussed throughout our session that bone health disorder, be it a metabolic bone disease, be it anything else, it starts right from the womb until the death. And at the point of presentations, people, majority of them, they do not come to us as endocrinologists. Mostly it is a referral. So they either go to the orthopedician, they go to the pediatrician, sometimes to the neurosurgeon also for a back pain where they're found to have osteoporosis and still not referred to us. So it is important because the endocrinology part of workup, diagnosis, use of the technologies to diagnose a problem, be it a DEXA, be it biomarkers that we have discussed, is something which is important for us to work up and identify what is the problem. But the pediatricians are the one who are the people who are to identify right from the beginning. So the basics of the training to catch the disease in those group of patients and refer to us, giving the importance of management of at least an adequate vitamin D, calcium intake, See, we saw in Dr. Nagesh's presentation, the child had received 4.8 lakh units, and still there are pediatricians who carry on the concept of STOS therapy. So revision of knowledge, that is important. Orthopedicians are the one who have to be involved if when we want to deal, as Ramesh has pointed out, FLS is something which is lagging behind in our country. So they are the people who are to look into the biomechanical part, because I find that the place where I am working, the orthopedicians are only interested in fixing the fractures, and then they do not even bother to refer the patient to take care of the osteoporosis, where they will be having T-scores of beyond -3. Gynecologists are the people who do play a very important role, because they are the one who can tune in the patients for a HRT. So as endocrinologists are, when especially in the lower economic strata patients, even we enforce on them to go for HRT. So but their rapport with the gynecologist are something which is better. So every institute must have a collaboration between these 4-5 fraternities, and have at least a bi-monthly or a monthly meeting where they can have an identification. Because in India, 150 crore population, I do not think hardly 0.1% of the patients must be getting a bone health care. So definitely involvement of these fraternities is something which is important. And maybe if we have a data, as Ramesh has put up, where there can be involvement of these people also, and we have maybe in future a consensus or guidelines kind of something, where of course all the people can be, their knowledge improvement is also something which is important.
Thank you, Dr. Ipsita. So the thing is, what I can understand is research collaboration will make all the clinicians to put on a similar platform to help the patient achieve a better bone mass, initially by pediatrician, by gynecologist and orthopedician, not only fixing but continuous care, so better care. Now, coming to Dr. Ramesh, as we have said, we need a research collaborations between many things to generate the data, registry. End of the day, we need in the translational science where basic research need to be translated into clinical care. So my point is, you already initially highlighted for predictive tools like Indian Frax score, because we are using Singapore or AI predictive tool. My point is how this collaboration can help in the going to laboratory medicine and all these clinical care into guideline generation and clinical care of the patient. How you see that?
Okay, yes, everything. Any research that doesn't translate into clinical practice is, I think, it's somewhat futile. Somewhat, I would say. Not actually. So, what I like. But if the research has to stem from a basic aspect, so there has to be involvement of a basic researcher. So if I am to put my point of view, I am a pure clinician. I'm a clinician and a clinical researcher. I have very little basic knowledge, very little, yeah. But what we have is, in our institute, we do have a very strong collaboration between our clinicians and our basic scientists. It's a very, very strong collaboration. So yes, so this collaboration is bound to this is something that has to happen. A collaboration between a basic researcher and a clinical scientist has to happen to translate any aspect. Translate any aspect of science, I would say, not only bone science, any aspect of science into clinical practice. So yes, probably the thing would start with a basic researcher. Basic researcher might develop a new molecular target, maybe a new microRNA or some new gene whatsoever. This should be followed by a lab medicine specialist, maybe a biochemist who will validate these biomarkers. Subsequently, what probably clinicians, we step in, where we will try to find out, validate these findings in the real world setting. And once that has been validated, probably that will be, then it would be the responsibility of stalwarts, probably stalwarts in the field of bone, maybe stalwarts in the field of other stalwarts, and these stalwarts and for these stalwarts, society should kick in, like the Endocrine Society of India or the Indian Society for Bone and Mineral Research. The stalwarts would come together and put together guidelines or consensus statements. So that's it. So I think each and every aspect of this translation is important. Translation cannot happen without a basic researcher, without a biochemical, without a biochemist, without a clinician, and without stalwarts. Who are part of noteworthy societies. And another form of, so this collaboration can be, as I said, what I was talking about was mostly intra-institutional collaboration. I am collaborating with my basic researcher. My gynecology, our institutional orthopedician are collaborating with me. So the collaboration, obviously, it has to go beyond intra-institutional to inter-institutional, of course. So yeah, we even collaborate with other institutes like IIT Ropar. So basically, IIT Ropar is very close to Chandigarh. So we collaborate with basic researchers in IIT Ropar. What we provide them, we are able to provide, clinical data to them, and they are able to process that clinical data and come out with some basic aspects of the clinical data. So now you can talk about, like, it is both, it is like we are going from bench to bedside, and again from bedside to bench. So it is not always that that basic researcher will be followed by a clinician. It can also be a clinician clinician helping a basic researcher to generate a basic data, which can subsequently be translated into a clinical data and subsequently be helpful in clinical care. I'm not sure how good I've been able to explain it, but I think, it is just, this entire chain is indispensable. Entire chain involving basic researchers, biochemists, lab specialists, clinicians, and stalwarts in the scientific societies is completely indispensable.
Thank you, Dr. Ramesh. What I can understand it is actually a bidirectional
absolutely
flow of the research which can translate. Though my question was a unidirectional from basic to clinical, but yes, we are true. Even clinical need to be retrospectively taken care by basic science once again, so it can help in finding newer pathways of disease, molecules, tests, drugs, and these can lead to validation by again going back from bed to bedside, validation of our results to formulate new guidelines and the clinical care. Thank you, Dr. Ramesh. Now coming to next question, Dr. Sinjan. Today we are discussing osteoporosis specifically. So how, if we talk about this collaboration, can affect osteoporosis management as well as fracture prevention from patient guidance? So we can improve the patient guidance by this collaboration. How we can do it, and what are your take?
Right, sir. So I think that's what Ramesh sir has already told. I can just extend that explanation. So we have a collaborations between institute. We are making the various guidelines, international guidelines, as well as we have a very standardized ISBMR guidelines for treating osteoporosis. So the most important aspect is to find the case, because we need to do DEXA more often, specifically on the indications. The indications are very specifically laid in the guidelines. So we need to find the cases first, then treat those cases according to the guidelines by anti-osteoporotic therapy. But most importantly, our duty doesn't end with just treating those patients with anti-osteoporotic therapy. Raising awareness of osteoporosis among the whole society is very important. And very importantly, the patients who are found to be osteoporotic, we need to prevent the fractures by preventing the falls. By preventing the falls is basically the patients like the diabetes, which we were discussing. They are very prone to have sarcopenia, sarcopenic obesity. So they are very prone to fall. So how can we prevent those falls? That is very important. And a very simple thing like the exercise, the daily physical activity, which we are advising for all diabetes patients, are also very pivotal in managing the osteoporosis patients and improving the bone health. So all these parameters or the components is actually forming the fracture liaison services, the FLS, which we call. So these things has to be implemented in India in a very coordinated manner, and probably I would request all the societies, ISBMR on the Indian Endocrine Society of India, to formulate the FLS plans like some of the Western countries, even like Japan in the Far East. They have a very standardized FLS programs, which we should implement, and where all these components will fall in place, and with collaborations, we can be very much helpful to prevent the fractures, specifically the osteoporotic fractures.
Thank you, Dr. Shinjan, for your views. We know often we consider that the peak bone mass is an unmodifiable factor which we can't change. But changing this dogma, we all of know because of the changes, the we need to address this issue of bone health, not at the end of our lifespan period at the 60 and 70. We need to take up in this childhood. So my question to Dr. Ipsita is how we should guide patients, particularly not patient, I will say, pediatric segment, children and adolescents, to help them to achieve peak bone mass. Because we achieve peak bone, then there will be less risk of osteoporosis. So your guidance on these points, how we can help them to achieve a better peak bone mass. Dr. Ipsita.
Okay, so as we know that the definition of when the peak bone mass is laid down, it is usually at the second decade of life. That doesn't happen. The bone mass actually starts right as the kids they enter into the pubertal age groups. So there it happens and happens. But that is not the strategy. The bone health starts laying down right as we have discussed throughout when the child is inside the womb of the mother and throughout and beyond. Now, this is a very saddening aspect because as I see the kids and the society growing up, our awareness about the bone health diseases is poor. So what is going to happen to these group of kids down the pipeline that only God knows? So I believe that there are 4 to 5 components when we talk of bone health: nutrition, lifestyle, exercise, family, genetic part, which is of which we cannot do much of any modification, but the other components they do play an important part. So throughout the until 18 years of age, if you divide them, the preschool, the toddlers, the school going kids, and then the adolescent groups, so everyone, the nutrition related part is something which is important. And with the changing times, then definitely the components of the nutrition is varying. It's not just in the tier 1 but in the tier 2 and the tier 3 cities. The importance of a balanced food habits is coming down. So a balanced diet, a calcium rich diet, incorporation of a family based foods which can be commonly taken, which includes calcium based diet. So Indian foods, they do have it, but the consumption of those is something on a lower side. So if the pediatrician, when the child comes to them right from the stage of birth and immunization, so at that point, if the reinforcement is laid down, especially to the parents, then that is something which is important. And as the child moves on, so now the physical related activities are coming down. So more of screen time, more of studying time. So as Grimish has told, so bone and muscle are something which are very much coordinated. So each take care of everything. So the muscle related component is something which is lagging behind. So importance of physical activities, resistance training should be emphasized, and it has to be taken at a societal level where the schools also must be involved, and the awareness of all these components must be taken. So much of sun exposure is something which we cannot do in India. So at least an adequate calcium and a vitamin D diet component is something which needs to be imparted, the knowledge, and of course the involvement of the parents, the family, because still India believes in more of cereals. So cereals are rather serial killers, which I believe. So that is something where our diet part is something which is lagging. The play part is something which is lagging. And as the kids are moving now, with the use of the processed foods, the beverages, adolescents, they consume more of that. So, and we know that those are something which are going to kill your bones ultimately. So those things needs to be trained. So all said and done, I believe that uh, uh, awareness is something which is rather important. So if somebody identifies that if I do this and it is going to create problem to me, then only they can, they have the awareness and they can improve in their activities, their way of living. So that is the way in probably which they can improve everything.
Thank you, Dr. Ipsita. What I can summarize is we need to sensitize the importance of nutrition, balanced diet, protein, calcium, resistance exercise, and not only to individual, but their parents as well as the society. Thank you, Dr. Ipsita, for your inputs. Now we are already overboarding the time. So over to Dr. Khushbu for next panel discussion. Over to Dr. Khushbu Agrawal.
Thank you, team. Great panel discussion. So we'll go to the last part of the discussion, just read by Dr. Khushbu Agrawal. May I have the CV slides, please? Dr. Antrisa, please take over.
So I would like to invite Dr. Khushbu and the panel members, Dr. Kripacharyan, Dr. Asim Maldar, and Dr. Ravindranath Reddy on the panel discussion about treatment of osteoporosis. Khushbu is an assistant professor in the Department of Endocrinology at CMC Vellore. She is a winner of ESI Uratna Award and IJEM Best Researcher Award and has multiple publications to her name. Dr. Kripa Elizabeth Cherian is professor of endocrinology at CMC Vellore. She is a winner of AR Seth Award and the prestigious Phil Leroy Award. And she is a reviewer of multiple international journals along with more than 115 publications. And she's also a past winner of Uratna
Slides
Award.
have to move. The slides are not moving. CV slide is stuck. Yeah.
Next, I would like to introduce Dr. Asim Maldar, who is a senior consultant at PD Hinduja Hospital, also a winner of ESI Uratna Award and Anlar Seth Award, and along with the Young Researcher Award. And he's also Dr. is also a reviewer of multiple national and international journals. And I would like to also invite Dr. Ravindranath Reddy, senior consultant in Wasabi Endocrinology Clinics, and is a multiple award winner in various conferences like Speedocon, Inspire, and Esicon, along with multiple publications and a few original articles also. So I would invite the moderator and the expert panelists for an enlightening discussion on treatment of osteoporosis.
Dr. Khushbu, you have a slide to share as well, right?
Yes, sir.
Can you go ahead, please? Yeah. Yeah.
Are my slides visible?
Coming. Just let us wait for the final thing. Yeah, it's here. Go ahead.
Sure. Thank you, sir, for a warm welcome to all of us. So, coming to the most exciting part of today's discussion, we are going to have a discussion. Osteoporosis is an important disease, and while we may have a nice discussion about what to do about it, so we thought that we can discuss about how to treat osteoporosis, and I have got three very eminent speakers with me who are going to guide us on how to go about the treatment. So, without further ado, my first question is to Dr. Asim Maldar. What are the indications to start treatment for osteoporosis, sir?
Yeah, hi, good evening, everyone. And first of all, let me thank the Endocrine Society of India and Dr. Mohan, Dr. Lakshmi for organizing such a eventful program on the occasion of World Osteoporosis Day. And it was a great learning for me today. I mean, listening to the sessions earlier and the panel discussion as well. So, coming to the question, what are the indications to start treatment for osteoporosis? I would like to divide it into three things. I mean, one is the clinical, then imaging part, and then something like use of various assessment, fracture risk assessment scores. So we are quite, straightforward. A person who has had a fragility fracture. So fragility fracture or a low trauma fracture. Simply put, that a person should not have had a fracture with that amount of trauma. And if there is a fracture, it indicates that there is very likely an underlying osteoporosis. So that is one major indication where we can actually go ahead and start with pharmacotherapy. So with pharmacotherapy, I actually mean specific anti-osteoporotic drugs. Of course, all the people, especially postmenopausal women, we do need to advocate about adequate calcium, adequate vitamin D, exercise, not only about cardio training, but strength training and balance exercises are important. And again, an important thing is adequate protein in the diet, which we usually tend to forget, and fall prevention. So clinically, yes. And if you're looking at bone mineral density, a bone mineral density score poorer than -2.5, T-score less than -2.5 is one of the indications to which suggests that there is osteoporosis. Then there is an issue which comes in wherein what happens if there is a low bone mass, but it is not, in the range of osteoporosis, something like a T-score between -1 to -2.5. So therein, we have already heard Dr. Om also speak about the use of bone turnover markers. Along with it, what usually we advocate is the use of FRAX, which is quite commonly easily available online scoring system wherein we put the clinical data. Even with or without a BMD value, the FRAX can be calculated. There are various thresholds which have been advocated. 10-year risk for major osteoporotic fracture more than 3% and major osteoporotic fracture more than 20% and hip fracture more than 3. And even I think Dr. Kripa was also a part of the study where there are some Indian cutoffs which have been advocated, more than 9% for major osteoporotic fracture and more than 2.5% for hip fractures. And like I said, there are various clinical scores which have also been validated in the Indian population, including OSTA, OSTA, or SCORE, or MORES for male osteoporosis. So these are various indications that I can say that wherein we can advocate pharmacotherapy or specific pharmacotherapy for osteoporosis.
Thank you, sir, for such a detailed answer. I think we are going to realize that more often than not, we are going to need treatment for osteoporosis. So my next question is to my thesis guide and the person who taught me everything about osteoporosis. So before we come to the medical management, what are the general non-pharmacological measures that are important in osteoporosis management?
Thank you, Pushpu, for that question. Thank you, ESI. Thank you, Lakshmi and Dr. Mohan for this initiative. So I think Dr. Asim has touched upon some of those general measures. So what I would like to stress here is that it is not enough to just leave the patient with a prescription for calcium and bisphosphonates. It is important that we educate the patient. So general measures are very important. Look at the patient's drug because many of them are elderly. They must be on polypharmacy. Are they on medications and excess of antihypertensives or diuretics that can cause them to fall? Do they have other neurodegenerative conditions, unstable joints, peripheral neuropathy, impaired vision that can predispose them to falls? So these are things that really need to be looked for and addressed. Of course, it's important that you insist that the patients and the caregivers make their homes safe and hazard free. For example, the use of assistive handrails, adequate lighting in the house, make sure that the floor is not wet, that they slip and fall, things lying on the floor. So these are all simple measures that can be taught to the patient. Similarly, excess of alcohol consumption, smoking, patients and individuals do need to abstain from these. Glucocorticoids, if it is indicated, should be down titrated to the lowest possible dose that is required. Again, physical activity is very important, graded weight bearing. It is also important to avoid certain types of exercises like too much of bending and twisting forces on the spine should be avoided. Apart from that, diet is very important. Encourage that they take adequate dairy products and also vitamin D in addition to a supplement if the dairy intake is not adequate. Now, the theme for this year's World Osteoporosis Day was the overlooked crisis in osteoporosis care. It's just unacceptable. So if we can educate our patients to bring back some of their relatives, their sisters, their mothers, their aunts, their cousins, elderly men to screen for osteoporosis, I think that is one more thing that we can do in osteoporosis care, prevention, and management.
Thank you, ma'am, for that wonderful answer. My next question is to Dr. Ravindranath Reddy. So my question is a very long question. So please tell us about the various anti-resorptive therapies that are available. What are the advantages and contraindications that we have to keep in mind when we are using a particular drug?
Hello, good evening, everyone. It's pleasure to be a part of this panel, and thank you, ESI, Mohan sir, and Lakshmi ma'am for this opportunity. So, after the detailed non-pharmacological management discussion, when we go to the pharmacological management of osteoporosis, it is divided into anti-resorptive therapy and the anabolic therapy. Coming to anti-resorptive therapy, there are some main classes of drugs like bisphosphonates, denosumab, selective estrogen receptor modulator, and some weaker drugs like hormone replacement therapy and also the calcitonin. First, coming to bisphosphonates, they are internalized by the osteoclast and they inhibit farnesyl pyrophosphate synthase enzyme and they induce osteoclast apoptosis. By this mechanism, they will inhibit the bone resorption. And the major advantage of this drug being it has a very long skeletal half-life with residual, which gives it a residual benefit even after discontinuation. The studies have shown that it has a proven vertebral fracture reduction and also non-vertebral fracture relative risk reduction ranging up to 20%, and oral options are also available for bisphosphonates. Whereas coming to the major contraindications, it is contraindicated in with EGFR less than 30 ml per minute in those with vitamin D deficiency and hypocalcemia, whereas the oral form is contraindicated in those with esophageal disorders like achalasia and Barrett's esophagus. Next, coming to denosumab, which is a monoclonal antibody to rank ligand. The major advantage of this drug being it is a very potent anti-disruptive, and the FREEDOM trial has shown that there is nearly 70% relative risk reduction of vertebral and 40% relative risk reduction of hip fractures with this drug. It is safe to give in CKD patients, and it is subcutaneously injected and every 6 monthly, and it is easy to administer when compared to the IV options. However, it is contraindicated in those with hypocalcemia and pregnancy. Now, the third option being the selective estrogen receptor modulator, where it acts as an agonist on the bone, whereas antagonist on the breast and uterus. So the major advantages of this drug, there is a significant decrease in vertebral fractures, nearly 40 to 50%, and there is also decreased breast carcinoma, and it is useful to preserve bone in the early menopause. However, the major contraindications for use of this selective estrogen receptor modulator, that is raloxifene, is it is contraindicated in those patients with venous thromboembolism, stroke, and cardiovascular disease. However, this drug has no effect on the non-vertebral fracture.
Thank you. Thank you. So my next question is to Asim, sir. So could you tell us about the various anabolic therapies that are available in the market? What are their advantages and their disadvantages? And if there are any precautions we should take while we start the medication?
So we have already heard about the anti-resorptives. So anabolic therapy still recently, I think in mid-2024, we only had teriparatide. Teriparatide, which is a recombinant formulation of our endogenous PTH hormone, 34 amino acid sequence, and it has an effect which is identical to the PTH. So when given intermittently, it has an anabolic effect on the bone. So it has been approved for use in postmenopausal osteoporosis, in men with osteoporosis, and in people on glucocorticoid therapy. Contraindications wise, teriparatide is contraindicated in people with hypercalcemia. That is one. So we have to look at calcium levels before we initiate teriparatide therapy. Also, people with CKD, it is very important that we look at the CKD MBD, that is metabolic bone disease status of the patient, and use of teriparatide should be with caution, if at all, in people who have an aerodynamic component rather than in people who have a very high bone turnover state. And teriparatide, we know that it is usually used for up to 24 months, and it has demonstrated BMD gains, bone strength improvement, as well as fracture prevention compared to placebo. And the duration of 24 months is important, wherein we use for the whole duration, the effects are much better as compared to use for 6 or 12 months or so. Usually, there is also a trend to reinitiate teriparatide after a few years if the bone density deteriorates or if there is a new fracture. However, evidence regarding this practice is not very forthcoming. The other recent drug that we have in our armamentarium, which can be considered anabolic therapy, is romosozumab, which is a humanized monoclonal antibody against sclerostin. And the FRAME trial has shown that romosozumab versus placebo over a year, it shows that all the aspects of bone mineralization, BMD gains at all sites, as well as a reduction in risk of vertebral, clinical, as well as non-vertebral fractures is seen. And anabolic therapies, yes, they are approved for people who have severe osteoporosis, multiple recurrent fractures, BMD worse than minus 3.5, fractures on anti-resorptive therapies, or fractures on ongoing glucocorticoid therapies, etc. So romosozumab, it is contraindicated in people with recent history of myocardial infarction and stroke. Again, as with denosumab, we have to correct hypocalcemia and hypovitaminosis D before we initiate romosozumab. So I think these are the two options that we have for our clinical practice, which can be considered as anabolic therapies.
Thank you, sir, for such a nice answer. My next question is to Dr. Kripa, ma'am. Once we have given an anti-osteoporotic agent, how are we going to follow them up?
Yeah, I think this is a very important question, as someone else had alluded to in this webinar. Diabetes and hypertension are chronic diseases. We have definite targets with which to follow these patients up. For example, in diabetes, you would target an A1C that's less than 7. For blood pressure, you may want to keep it less than 130. But what do you do for osteoporosis? So the goal so now the paradigm shift in osteoporosis management has changed from a step-up therapy to a target approach and a goal-directed treatment approach. So in which your target or your goal is to prevent a fracture, number one, and secondly, to stabilize the BMD. So osteoporosis requires lifelong follow-up. That's the first point that I would like to make. So if on an anti-osteoporotic agent, that you've given, the BMD has at least climbed to the osteopenic range. The bone turnover markers are acceptable. Bone resorption is not high, and the patient has not had a fracture. Then the anti-osteoporotic treatment can be withheld, and the patient can be followed up again with bone biochemistry, bone turnover, and a DEXA scan, which you will do annually. If a patient has sustained a fracture on existing therapy, for example, bisphosphonates. That indicates that the patient has not responded to bisphosphonates. That is always an indication to escalate your therapy to either a more potent anti-resorptive like denosumab or anabolic therapy. And again, at every visit, it is important to ensure that the patient is compliant to medication and has not fractured. So osteoporosis is a chronic disease that requires lifelong follow-up. And I think this is a very elaborate session, which I cannot condense in 2 minutes. So any doubts, I'm happy to take it later as well.
Thank you, ma'am, for that answer. So my last question is to Dr. Ravindranath. So we have already discussed that diabetes is there, and see the most common cause of diabetes, most common cause of CKD is diabetes in our country. So and osteoporosis is also a public health problem. So what happens when you have osteoporosis and CKD in the same patient? How do you manage bone health in such a patient?
Yes, ma'am. So, management of osteoporosis in CKD, it's not straightforward, and as osteoporosis always coexists or overlaps with CKD MBD. So, before we treat any patient with osteoporosis and CKD, we must first identify what is the bone phenotype, whether it is a high turnover state, low turnover state, or a true osteomalacia or true osteoporosis. So, the treatment is based upon the bone phenotype and also the EGFR. The Endocrine Society and ASBMR guidelines and KDIGO guidelines state that the patients with EGFR 1 to up to 3A, that is, with EGFR more than 45 ml per minute, the management is similar to that of general population. However, in those with EGFR less than 45 ml per minute, including those with dialysis and undergoing dialysis and renal transplant, the treatment is changing. In those, we will first see what is a bone phenotype. If they have high turnover state, that is a secondary hyperparathyroidism, our first focus will be on managing the CKD MBD by using calcium mimetics and phosphate binders. Later on, we'll be treating the patient. If turnover is normal, then bisphosphonates can be considered if EGFR is more than 30 ml per minute. However, they have to be avoided surely in patients with low turnover state and hypocalcemia. Next being the denosumab, it is significantly preferred in those with low EGFR because it is not renally cleared. But the major disadvantage with denosumab, these patients can have severe hypocalcemia. So they have to be monitored after 3 days and after 1 week after the injection. And the calcium and activated vitamin D has to be uptitrated post this injection. FDA in 2024 has also issued a box warning regarding severe hypocalcemia with denosumab in patients undergoing hemodialysis. Whereas if the turnover is low, then our adynamic bone disease, anabolic treatment like teriparatide can be considered. However, it has to be only started after the low turnover status is confirmed. So, to finally conclude, treatment of osteoporosis in CKD and dialysis patients, it has shifted from uh, exclusion to a personalized inclusion guided management, where we need to take into consideration all the biochemical phenotype, the turnover status, and also the safety profile of the drug before managing these patients. Thank you.
Thank you all for a very wonderful discussion. So I would like to end with this wonderful cartoon. We have an aging population, and osteoporosis is a public health problem. Hip fractures are associated with 20% mortality in the first year. So, and 1 in 2 postmenopausal women will have a fracture. So, and unfortunately, our country has osteoporosis at least a decade before the Caucasian population. So, we should take the treatment very, very seriously. Thank you.
Thank you, Dr. Khushbu and team. It was a very enlightening discussion on the topic. And as always, we had finished ahead of time. And I would like to invite Dr. Mohan T. Shenoy sir and Dr. Lakshmi Nagendra ma'am to deliver the vote of thanks. Dr. Mohan T. Shenoy sir is a senior consultant endocrinologist in Sri Gokulam Medical College, Trivandrum, and Lakshmi ma'am works at JS, also assistant professor at JSS Medical College and consultant endocrinologist at Magna Center of Endocrinology. Both of them are dynamic and omnipresent, and also Lakshmi ma'am is an ESI faculty member, and they are all the upcoming phases of ESI. So I would invite Dr. Mohan T. Shenoy sir and Lakshmi ma'am to deliver the vote of thanks.
Thank you, Dr. Antrisa. I hope the audience who have joined here today, as well as the faculty, have benefited from the knowledge that our speakers have given us. I will be very brief because last 2 weeks back only we thought about this. Do you know that osteoporosis week is only next week, but we have Deepavali, which is also a bright and holy festival. So I was personally thinking that it would be best to start 1 week ahead of the Deepavali so that our knowledge will spread out when we reach the actually osteoporosis day. So that is my personal basis why I just thought about it. Thank you, Lakshmi, for helping hand and join task force with us. Pediatric Endocrine Task Force and Skeletal Task Force have collaborated first time. So it's a great opportunity. Thank you to ESI. It's my duty to start the vote of thanks. Now, first of all, let me thank the entire ESI EC members and President Dr. Kaushik Pandit sir, who despite being away for a scientific commitment was able to guide us and definitely provide us insights in his opening address. Thank you, Dr. Kaushik Pandit sir. Also, kudos to Dr. KVS Harikumar sir, who is always with me on Lakshmi, and he's always telling us to go ahead and totally encouraging us. And all the ESI members also will benefit from you. Thank you, sir, for that opening address and the opportunity. Dr. Thomas Pearl sir gave us a great message in the start, telling us that we should all look forward and do collaboration and also help in liaison for fracture management. So that is a very good thing. And osteoporosis theme itself says bone health matters. And we should definitely spread the right message that endocrinologists are definitely the main players in osteoporosis treatment, along with the other team members. Thank you, Thomas Pearl sir, for that message. Also, Dr. Sri Nagesh, as usual, he dealt with a very complicated topic of spectrum of pediatric bone disorders with 2 excellent case-based approach, because that is important for the practitioners, pediatricians who refer to us, the patients who also see these things. So definitely that is one of the major things, how he showed us the 10-year follow-up data. That is definitely what we should do as a practitioner. It's a very much eye-opener for me to keep data safely and to project the data right to the people in the world, like world-class players. That's also important, how to write a paper with this. And also when you want to ask an expert what to do it, that's the way we should, as upcoming people should do. That's the right message. Thank you, Sri Nagesh sir, for that bright and brilliant talk. The second speaker, Dr. Om J. Lakani, as usual, really, I'm not surprised by his beautiful talks and the way he simplified the entire topic of bone health, by the bone markers and the fracture risk management. He gave a very bird's eye view of how we should do as endocrinologists and and to help each other and learning about bone biomarkers. He showed some good research data. Thank you, Om, for the beautiful talk. Both the panel discussions were very crisp and concise. The first panel was led by Dr. Umesh Kumar Garg. The topic was osteochronology, research collaboration, and patient guidance. The term may be a bit like a simple term, but osteochronology is definitely the one which we should always try to embrace. Maybe that is the one term which we should go ahead with. Research collaboration is definitely the thing in the future. So we have a lot of researchers in here. The Endocrinology winners are also here. But definitely we should all try to collaborate. There is nothing difficult to us. We should all do together only. Dr. Umesh simplified the topic. Dr. Ipshita Mishra, Dr. Ramesh Pal, and Dr. Shinjan Patra from institutes joined. Umesh is a very good help with me. Personally, whenever I give any task to him, he takes to his heart and devotes totally to it. I really thank him for it. Dr. Ipshita and Dr. Ramesh Pal and Shinjan did a very good job in the panel. Thank you all of you for doing the great, excellent work. The second panel discussion was led by Dr. Khushbu Agarwal, who definitely has a bright future, and she guided us on the treatment of osteoporosis along with the experts, Dr. Kripa Elizabeth Cherian, Dr. Asim Maldar from Mumbai, Dr. Ravindranath Reddy from Kurnool, Andhra Pradesh. It is really important that these topics are heard by the people around audience. We have recorded these sessions on YouTube and we'll share it to all of you. You can go through that because slides were very simple and lucid. These are the way we should tell our patients how treatment is very important for them for long term. Dr. Khushbu summarized the entire thing by showing the tree. We should try to climb the trees holding each other's hand and not criticize each other. That is what we should do. And we should learn from each other and come up from experiences. So I thank all of you who have joined today. I thank Dr. Lakshmi Nagendra for helping me with this, creating this beautiful scientific program. I thank the technical team led by Bashiruddin Sheikh, Abida, and all the members for joining today. I really thank all of you. I also wish that we have future episodes like this. A small word from Dr. Lakshmi as well. Dr. Lakshmi, please.
Thank you, Dr. Mohan. I think the vote of thanks was comprehensive. Thank you, everyone, for joining us. Let's work together to improve awareness and also treatment of disorders related to osteoporosis. Thank you and good night.
Thank you very much. So we'll close the session. Thank you.